All right, let's jump right in. Today, we're going to tackle one of the most common consults in hematology, the initial management of adult immune thrombocytopenia. If you're a trainee, think of this as your go-to guide for those crucial first steps.
Here's our game plan. We'll start by getting our heads straight about the real goal of treatment. Then, we'll walk through that big decision to treat or not to treat. We'll cover what to do in a true emergency, break down your first-line options, and then take a quick peek at what happens next.
So picture this. It's a classic scenario, and I guarantee you'll face it on the wards. The labs come back, and they look, well, scary. But the patient in front of you, they feel totally fine. So what do? Your answer here is really the heart of managing ITP.
But before we can even answer that question, we have to kind of reframe the problem. We need to establish the single most important principle of managing ITP. Okay, just a quick refresher. ITP is an autoimmune thing, right? The body's own immune system gets confused and starts attacking its platelets. And it's super important to remember, it's a diagnosis of exclusion. That means you've already done your homework and ruled out all the other stuff that can cause a low platelet count.
And this is the whole ballgame. If you take one thing away from this, let it be this. Our job is not to chase a number on a lab report. Our job is to protect the patient from bleeding. Seriously, a patient with a platelet count of 40,000 who is stable and not bleeding, that is a huge win. That's a treatment success.
So, keeping that core goal in mind, how do we approach our patient with a platelet count of 12,000? Well, you need a clear framework, a way to think through the decision.
And here it is, a simple but really powerful framework. Just ask these 3 questions in this order, and it'll guide you every time. You start big picture. Does this patient even need treatment? Then you get more specific. How urgent is this? And finally, you get practical. What tools do I have to work with?
So first question, who needs treatment? As a general rule of thumb, the guidelines point to this number, less than 20,000. Why? Because at this level, even if the patient feels fine, the risk of a spontaneous, significant bleed starts to become a real concern. So we step in.
Now, on the flip side, what if the count is 30,000 or higher and the patient isn't bleeding? In that case, just watching and waiting is often the best move. Remember, treatments have their own risks, and at this platelet level, the risk of a major bleed is already pretty low.
But these numbers, they're not absolute laws. And here's where you really start to practice the art of medicine. Just look at how dramatically age changes the picture. The risk of a severe bleed jumps almost tenfold in patients over 60. This is huge. It's a critical factor that can totally override the platelet count alone. An 80-year-old with a count of 25,000 is a completely different clinical challenge than a 30-year-old with the exact same lab value.
Okay, let's shift gears to the most high-stakes scenario you can face, a patient who is actively, seriously bleeding. This is when that second question in our framework, how urgently must I act, gets a very, very clear answer, right now.
So what do we mean by critical bleeding? We're talking about bleeding into a critical spot, like an intracranial hemorrhage, or bleeding that's so bad it's causing hemodynamic instability. This isn't just urgent, it's a true medical emergency.
When this happens, your response has to be immediate and multi-pronged. You need a playbook. So here it is. Step 1, transfuse platelets to get a quick, temporary boost. Step 2, you do this at the same time. Give intravenous immune globulin, or IVIG, to block the destruction of those platelets you just gave. And step 3, add high-dose glucocorticoids to start shutting down the whole underlying immune attack. This 3-step approach is your emergency protocol.
Okay, let's take a deep breath and step back from that emergency. For most patients who need treatment but aren't critically bleeding, you've got 2 main tools in your starting lineup.
The choice between glucocorticoids and IVIG really boils down to a classic trade-off. Steroids are cheap, they're easy to get, you can give them orally, but they're slow. They can take up to 2 weeks to really kick in. IVIG, on the other hand, works way faster, often within 1 to 3 days. But it's an infusion and it's a lot more expensive. So the deciding factor is urgency. How fast do you need that platelet count to come up?
So let's say you pick steroids. Well, you've got another choice to make. You can go with a short, high-dose pulse of dexamethasone. It's just 4 days, no taper needed, and you can get a faster response. The other option is a more traditional course of prednisone, which gives you more flexibility to slowly taper the dose down over several weeks.
So you've started your first-line therapy. But what happens if the steroids don't work?
Or what if the patient's platelets look great, but then they drop right back down as soon as you start tapering? What happens when you need to move on?
This is where we move into the world of second-line therapies for more persistent or chronic ITP. You've got options like thrombopoietin receptor agonists, we call them TPORAs, which basically tell the bone marrow to make more platelets. Another choice is rituximab, which targets the immune cells causing all the trouble. And finally, there's the surgical option of a splenectomy, which removes the main place where platelets are being destroyed.
You know, at the end of the day, remember that these guidelines, they're just that. They're a framework. They're not a cookbook with rigid rules. The real art of medicine is taking all this knowledge and tailoring it to the actual person sitting in front of you. When you consider their age, their lifestyle, what's important to them, that's when you move from just treating a lab value to truly caring for a patient. And that's how you'll master the management of ITP.